All right, well, good afternoon, everyone. Thank you so much for coming to this 3:30 breakout session on a Friday. We really appreciate your presence being here, whether you're here with us live or you're seeing this online. The name of this talk is called Assembling Your Super Team. So looking at maximizing outcomes with an interprofessional approach to services for your child. So we're excited to be here today, so thank you so much for attending. Before we begin, we just want to give a really fast, quick shout out to Autism Alliance of Michigan for putting together such a fantastic conference today. I know between as parents and educators alike, we've all been able to come together and share some really amazing information for our kids to help those we love live their best life possible. And that's really what we all want to do. We've all got that same goal in mind. So again, thank you to Autism Alliance of Michigan for being able to do that and for being able to put this presentation together with my fantastic team that I get to be a part of at work every day. So we're going to start here with a quote that autism does not come with an instruction guide. It comes with a family who never gives up. And that is our motto in our clinic where we are, and I think it's a motto everywhere. You can see we kind of have a superhero theme going on here, and you guys as parents are your child's first superhero, right? You are, with your invisible capes and all, you are their voice, you are their advocate looking for what is going to support them the best. And especially when you are looking for services, whether it's through the school, it's in the clinic, it's getting hospital and healthcare services together, you're entrusting professionals to really help you on the journey to success with your child, whatever that may look like. So we want to give you guys actionable tips and strategies and techniques to take with you wherever you are on your journey to say, oh yeah, we're doing this, or oh, these are questions to think about that I wasn't aware of before. So again, all practical information so when you leave here today, you can apply it right away. So now let's talk about these awesome superheroes that I get to work with every day who are all presenting together.
Yes, hello, my name's Christy Schoaf, and I'm a BCBA, which stands for Board Certified Behavior Analyst.
And my name is Susan Browning. I'm a speech-language pathologist working at Star Behavior Consultants in Shelby Township, Michigan.
And my name is Ashlyn Law, and I'm an occupational therapist, and I work alongside with these guys at Star. So before we get started, we first want to review with you guys our learning objectives. So our first learning objective is to be able to walk away from here and describe the difference in the roles of a speech therapist, an occupational therapist, and a certified behavior analyst. We also have a second learning objective, which is to recognize the benefits of your child's healthcare team being able to collaborate effectively together. And lastly, our third learning objective is to then identify the top considerations when you're looking to add a new professional to your team, maybe go to a new clinic or find a new setting. So we all here have been on a different journey, but I think there's one thing we can acknowledge. No one here has probably felt like their journey has been the straight line from point A to point B like you see on the bottom of the picture on the screen. However, you probably feel a little bit more like your journey is the squiggly line that connects them. So with that being said, the path from your parent or a doctor's suspicions of a diagnosis of autism all the way to that diagnosis and often beyond that diagnosis is quite a long and confusing journey. So we're here today to talk to you about that journey and kind of hopefully make those squiggly lines a little bit more bearable.
Mm-hmm. But first, you get your autism diagnosis and you enter down another squiggly path, and that is figuring out what options are there, what are the treatments that are being recommended to you and your family. So that journey might consist of a lot of appointments, potentially some evaluations or even some wait lists, unfortunately. And there's probably a bit of your own research. People get on Google and check out the different communities on Facebook and other social media where you can kind of hear about who the providers are in your community and kind of hear from parents that have had experiences there. But ultimately what ends up being recommended is generally a combination that you see on the screen here. You're going to see some school time likely, a different recommendation for hours of ABA depending on the kiddo's needs, and then speech and occupational therapy as well. There may also be recommendations for physical therapy or a social skills group or something along those lines depending on the child. which they're all really great treatments, but they can lead to some really busy schedules for our kiddos and our families.
And I think as all of us as parents, we have that understanding of what it's like to be running from here, there, and everywhere, right? Whether we're trying to just get ourselves out the door in the morning or take them to school, to any services that we may be going to. So these schedules can get crazy. So of course, as we talk about this a little bit more, we'll talk about those considerations, right, when we're trying to choose what's best. But with some, just a few questions, just to see how what you guys are up against. How many of you have a child that may attend 2 or more services a week? Do we have people that are attending services? Okay. So we've got that. Do we have, how many of you know that your child's practitioners are working together collaboratively towards their goals? And that may be one you're asking yourself, geez, I'm not sure, or we're not there yet, or geez, I dropped my child off at this place, I'm not quite sure what happens because I haven't been able to get in as a parent due to COVID restrictions, I'm not sure. So just something to think about there. And finally, and most importantly, do you like pineapple on your pizza? And yeah, I'm throwing it out there because I'm making sure everybody's still awake again, because I know how it goes after 3:30 on a Friday. But also, just to throw it out there, I personally do not like pineapple on my pizza. How about you, Christy?
I do.
You do?
I do. I hope that's okay.
And you're a board certified behavioral analyst, and I'm a speech therapist. We don't like the same things, but we can still get along really well.
Yes.
And all good things to collaborate for these common goals for the kids. So important. So awesome.
So as we mentioned, you're on some windy paths, but finally, yay, you found some providers that you like, and okay, you've got your schedule down, you figured out where you're going and when, and you can kind of breathe and settle in. But then a new issue might arise, and that's the main point of our chat today, and that is that your child is going to attend various services and settings, and you may receive recommendations that don't always align with each other. And that can happen in a variety of skill areas, but you can see on the screen, I've kind of illustrated one that talks about communication, which we know is one of the most important things for our kids. So let's say Johnny at speech, the speech therapist says, hey, he's getting these sounds down really great, and I think we would see some success if you pushed for them at home. So use E for eat and O for open, and push those, and we'll see where it takes us. And then the next day or the next week, your BCBA reaches out and says, I really think Johnny would do well with some alternative communication device. Maybe it's an iPad. Here's some links, Mom. Check them out. Get back to me. Let me know what you think. And then, next day or next week, here comes a core board in your kiddo's backpack because that's what they're using at school to help your child communicate. And if you're unfamiliar with a core board, it's basically just a picture that has what they call core vocabulary on it, and they're commonly used in schools. Oh, sorry, touched it. You're hearing all these people and you want to do everything you can for Johnny, and everyone sounds like they know what they're talking about, but you can kind of be left like this picture on the screen, like, that's a lot, how do I know exactly what to do when I only have so many hours in the day, and how do I know what's going to be best for Johnny when they're all telling me different things? So we know it can be confusing for a parent, of course, like, okay, you want to do everything you can, what do I do? But really more importantly, that type of scenario can be really confusing for the child, for Johnny, who is in those early learning phases of everything, and communication being at the utmost importance. It can be really confusing and take a lot longer to acquire any of those 3 variations of communication when we're providing inconsistent expectations. In a perfect world, our kids can do everything they're learning in any environment that they encounter. And consistency across those environments is really what's going to get us there. So getting on the same page is going to be really important.
All right, so as Christy just mentioned, let's all get on the same page when it comes to our child's care. So there's a few things we need to keep in mind. We have communication methods, We have behavior strategies, and we also have our general expectations about what our child can do in their everyday life. So let's start by thinking about the environments. What environments are we expecting our children to perform in? Are they going to school? Maybe they're older, they have a job, social skill groups, or extracurricular activities. So we need to think about all those different environments and then ask ourselves, are these different methods and strategies the same among all of those? And if not, what can we do about that? But before we dive more into that, we're gonna first off talk about and kind of just briefly go over each of the different services that you've probably been recommended. So up here on the screen, you can see we have some different common treatment recommendations. So first we have our special education services. So this is gonna be in the school, your teachers, your paraprofessionals, social workers along those lines. Also in the school, we're gonna have our school-based speech therapy and occupational therapy. Outside of that school realm, you've probably heard of ABA, so our applied behavioral analysis, and then also speech and occupational therapy, but more in a private or outpatient setting. And then, as Christy mentioned earlier, you might have been referred to physical therapy for various reasons, a social skill group, or other thing along those lines.
So first we'll kind of define ABA. If you don't know, there was actually a talk this morning about ABA today that was really awesome. So hopefully you got to check that out. But quickly I'll go through it. So basically it's an evidence-based treatment for autism based on the principles or the science of behavior. And we use those principles to make really meaningful change in the children that we work with. Two main components of the therapy are skill repetition, giving them lots of learning opportunities, and then following that up with positive reinforcement so that we'll see the skills continue. Goals are generally derived from assessments that look at the development of a typically developing child and what milestones they reach and when. And then your BCBA should be able to kind of break those long-term goals down into smaller, more achievable goals that translate to what are those skills that we're repeating on a daily basis. In addition to assessments, there's a huge parent component and home-based component in going into what that comprehensive treatment plan looks like. And there's a really big emphasis on generalization today, which when ABA first came out, that wasn't necessarily the case, so it's continued to evolve. And we know now, and we tell our behavior technicians that it's great when a child can do something in our clinic in ABA, but it really doesn't matter until it happens where it really should happen, whether it's on the playground or when they're at home talking to mom, when grandma calls, can they say hello? So there's been a really big push in our field recently to kind of make sure we have that bigger picture on the forefront of our minds.
All right, so just to give you a little background on speech-language pathologists, or also known as speech therapists, we address a variety of aspects of communication, and our services expand across the whole lifespan. So we work with babies in the NICU who have issues with sucking and swallowing, all the way up to older adults who've had a stroke and end-of-life issues. So we've got quite a big gamut. We work on listening skills, expressing wants and needs, so being able to understand what we hear and then be able to come up with the words we want to say to get those words out and express our wants and needs. We work on articulation, so the way our sounds are produced so that we can be intelligible and heard and understood by other people. We work on augmentative or alternative communication, also known as AAC. So maybe they have a lot to say, but the brain and the mouth just can't communicate for a variety of reasons. That's kind of the simplistic version, but working on alternative communication, whether it's in the form of technology with an iPad or it's something that's just a very simple letterboard, whatever they're working on. And we also work on voice, fluency or stuttering, and swallowing challenges. And we work in a variety of settings. So a little bit different than ABA that has an autism focus. Speech pathologists will work in schools, clinics, hospitals, nursing homes, home care, all over the spectrum. And I mention that just because as you're choosing providers down the line, that's going to become important in some slides you're going to hear a little bit later in this discussion. So it's just food for thought for the future.
All right, so what is occupational therapy? Or many of you have probably heard it referred to as OT. So occupational therapy really looks at what is it that you need to do on an everyday basis. So what do you need to do? What do you want to do? What are you expected to do? So specifically within the population of autism, we work a lot on activities of daily living, education, and play. So activities of daily living are going to be those activities that you do every day, basically to kind of survive. So being able to get up and get dressed, being able to take a shower, being able to feed yourself. And then we also work on that education and play, so kind of what school skills do we need? Do we need to be able to write, use scissors, ride a bike, play on the playground? What are the different things we want, need, and are expected to do? So then we look at and evaluate and treat the areas that are keeping us from engaging in those things that we do every day. So we have motor skills, and within motor skills, we have fine, visual, and gross. So our fine motor skills are going to be those skills that use the small muscles. You can typically think of this as those little muscles in your hands. So being able to use your fingers to manipulate a button, being able to open a cap on your water bottle, being able to hold a pencil and use it. And then we have our visual motor skills. So these are going to be using your eyes together with your body to complete a puzzle, or maybe look at a shape and then draw it yourself, or copy something down from the board at school. And then finally, we have our gross motor skills. So these are going to be those big muscle activities, so running, jumping, riding that bike, all things of that sort. We also look a lot at coordination and motor planning, so kind of overall how we use our bodies, how we interact in space, as well as strength and balance. And then most importantly in the setting, we work a lot on sensory modulation. So we look at the different senses, and then for each individual kiddo, look at which sense is it that they might be avoiding, or what sense are they trying to get more of? How can we better help them regulate and have impactful meanings in their everyday work? So kind of a great idea of this to better help you understand is, let's say you really have to go to the bathroom and you're somewhere that you can't immediately get to a bathroom, and it's getting worse and worse and worse. You're in that car and there's no bathroom nearby, and you start to lose the ability to think. You start to lose the ability to function. You're really kind of so caught up in need, that one want and need, that everything else outside starts to become a little fuzzy. So we can kind of picture that need, that you're not going to be able to really function well until you're able to relieve yourself, or in that case, get to an accident. And so kind of just picture that feeling there, and picture that as how our kiddos are kind of experiencing the world when it is a form of like a stim or a sensory need that they have, and that discomfort that's surrounding it.
I like that example just because, again, we understand our brain and our bladder can communicate. We know what the feeling is, right? And we know how to fix the problem to take care of it. Our kids with autism, oftentimes the brain and the body, whatever it is, might be pain response, might be just, these lights bother me, it's too loud in here, whatever it is. They don't know what it means, and they can't communicate to get it out. And so they're gonna communicate, but it's gonna be in a way where they're throwing themselves in the middle of the floor at Kroger or wherever it is. So we like to kind of use this example Ashlyn provided just to kind of give us, put ourselves as adults in their shoes, because it's always coming from a unique perspective when we are treating and helping these kids, but we don't always have necessarily the same issues going on. So it gives us something to relate to.
Thank you.
Yeah.
All right, so in addition to all these therapies we just covered, we also must consider our school-based services. So one thing to keep in mind in the setting is that oftentimes our goals in the setting is going to be academic and focused. So for example, your child in school, their OT was probably going to focus more on writing, copying down paragraphs from the board, being able to use scissors and glue, whereas that same kid in an outpatient setting might be working on adding new foods to their diet, maybe being able to button their shirt or go through their toileting routine without assistance. So it's something to keep in mind that schools, it's great, they're there to help us succeed in our academics, but we also need to keep that full picture of our child in mind and consider what services they need, and if they need more than just what is in the school service. And last but not least, in addition to all these therapies, we also must consider the home, and most importantly, you as the parent or caregiver. Your input as a parent or caregiver is more valuable than any testing measure we as therapists can use. You should be the center of your child's team, the team captain on this collaboration team. And so just keep that in mind, that you are the most important, and therefore we should make sure we speak up. We ask about goals. What can we add? Why hasn't this goal been addressed? What else can we do as a parent? Be an integral part of that team, and consider what is most important in your house. What things truly matter to you and your family that you would like to see a change in. So in other words, what we're trying to say is, as you can see, there's a lot of hands in this pot. There's a lot of people that are contributing to your child's care team. So we need to keep in mind that while we all have really good value and expertise, that the best outcomes we're going to get is when each of those people work together and use those same methods and strategies to truly come together and get those nice, big, generalized, exciting outcomes and meet all of our goals. One last thing to keep in mind, though, is from the start, we really do want to make sure we're working on transition services, because the end goal isn't for your kiddo to be in therapy the rest of their life. We want to really work on reducing those restrictive therapies and being able to be as functionally independent as possible. So we must make sure that wherever we're at, we are discussing that and knowing what the future may hold and going about it as it comes.
So let's get into collaboration. That's kind of our second learning objective, is how can we collaborate effectively? Thank you. I'll first acknowledge that it may not be easy. You know, there's time constraints and everybody's busy, and I know pretty much any other professional I talk to is busy. You know, they're on the run, they're running out the time of their clock. We wish we had more time in the day. With collaboration too, you have to compromise. You know, you may have to completely rethink. You might have the best idea for something, but if the other people on the child's team don't necessarily agree, you kind of have to compromise and rethink what you're going to do. At times, you may just have to agree to disagree and come up with something, you know, completely different for the child for the sake of their consistency and their success. And so we'll talk to you about getting it going. Sometimes your providers will just come out and ask you, you know, who else sees your kiddo throughout the week? Can I get their number? You know, can I reach out to them? I'd love to go see them at school or whatever it might be. But if they don't ask you, you definitely should ask yourselves. And a lot of times if you're talking to a private therapy clinic, there will be a form like the one on your screen. This is what ours looks like. And it basically just gives permission to, you know, specific people on what exactly they can share and who they can share it with. And that's how you kind of get them the other people's email addresses and phone numbers. And then I'll just throw in a tip to follow up about it. I know personally sometimes emails are sent and then they just sit there. And there's nothing that lights a fire more than a parent just saying, hey, did you talk to so-and-so? Did they ever get back to you? That can make the difference for the collaboration to really begin. And also it's your right to invite whoever you want to whatever meetings you want. So maybe you want the school speech therapist to call into your ABA treatment meeting, or maybe you want all of your people to kind of come to the IEP. And yes, there will be 15 chairs at the table, but everybody interacts with your child, so why not have everybody there? And then once it gets going, these are some examples of what collaboration might look like. So like I said, team meetings. Hopefully there's some observation between the different settings. It's easy when you're in a clinic where you've got lots of people on the team right there. It's a little harder when we're talking about going into a school, especially with COVID times. But that doesn't even just mean us observing. It could mean a parent coming in and observing our therapy so they can do stuff at home. There should be some carryover of skills and goals that are complementing each other and not combating each other. The use of similar materials, especially if there's maybe there's a behavioral challenge that's happening in all of the different settings. Maybe we use the same coping card visuals or the same type of timer, something that will help the child kind of cope in that moment and kind of get past that challenge. But that could also even just be fidgets for staying focused on a task. And then most importantly, you should start to hear somewhat similar feedback. I'm not saying a child is going to perform the exact same way in all the settings. That's not always the case, but if they're not, if they're really successful here and they're not so successful there, that should be known, and that should be a conversation of, okay, what are you doing? Because let's try some of those things over here. And there should be an ongoing discussion of that. Just some examples of collaboration that might occur outside of a clinic setting would be your technicians actually going into the home. So that could be an ABA technician or speech or OT. Whether that's home-based therapy, or we've had times where we'll just kind of go in for a big moment, such as potty training, and kind of show the parents in their bathroom and with their stuff what that might look like. Or feeding, you know, maybe they eat with us, but they won't eat at home. Not only can we collaborate with the teacher, but sometimes we'll actually have an ABA technician go into the classroom to assist with the transition from that, you know, restrictive one-on-one therapy to that less restrictive setting where there's a lot of kids and, you know, only a couple of teachers. And then community type collaboration may be worthwhile, such as haircuts. Sometimes those are scary and traumatic. Getting to the dentist, getting to the doctor. You know, there's a lot that we can do to kind of prepare a kiddo and get them ready for things like that inside the clinic, and then kind of help them move it into the community.
All right, so let's talk about a real world example on how we collaborate, you know, throughout the day. To give you an example, so we're going to talk about a little 4-year-old boy named Philip, and Philip comes to us. He's 4 years old. He comes to us. He does speak 2 different languages, so they do speak a language at home, and then he's learning English as well. He attends STAR every morning, and he receives ABA therapy, speech, and OT. He also attends an early childhood special education class in the afternoons through the school district. He loves his people, so he knows when he gets places who his tech is, who his BCBA is, who he sees for OT, loves everyone, speech, you know, all his people. Some of the challenges is he does have difficulty transitioning between caregivers in all environments. So when he's trying to separate from mom and dad when they drop him off in the morning, we're having some challenges if he's transitioning from being with maybe Christy and her team with the tech, and then he's coming to see me for speech. It's been it's tricky for him to kind of let go of the person he's with and then transition to someone new. And they're also reporting the same thing is happening in the schools as well when the teacher leaves. So he does have some limited spontaneous speech, but we also use PECS as a backup. And if you're not familiar with PECS, it's one of those augmentative or alternative communication systems we talk about, so it's called a picture exchange communication system. So we actually use that also because we realized he's a visual learner, so you see he's got visual strengths, so when he sees the picture, it helps him find the word a little more easily. He has limited functional play skills, so if you think about maybe a race car track and there's a car and kids like to play with that car going down the track, that's not him. He likes to take the car and kind of just look at it like this. And that's okay, but if that's how he plays with it, but what happens is it reduces his attention and engagement with others around him, so that's something that we're looking to address. So when we spoke with the parents about their main concerns, communication was number 1, potty training, food selectivity, making friends, and tolerating seasonal appropriate clothing, which in Michigan this week, I think we've worn several different types of clothing this week. And if you're somebody that's used to, you know, wearing a coat and you like the weight and it feels good to you, and then all of a sudden you can take your coat off, or you're hot, but you don't know what that sensation means and what to do, it's a challenge for parents, so we're working on it in treatment. So, I'll turn it over to you for those ABA goals. Sorry about that.
Yep, so from all the parent concerns, you'll see that they're kind of divvied up among the 3 of us. In ABA, communication is a huge thing that we're working on, both with that PECS-like system and then words and sounds. Looking at helping him identify and label things in his environment so he can better understand kind of what's going on around him and the language that's being spoken. We are working on transitions between activities and people, looking at playing with toys appropriately, and then, first step of potty training is not being afraid of the toilet. So that's kind of where we're at, desensitizing the toilet itself and the flusher and the bathroom and all of those things.
So from an occupational therapy perspective, in collaboration with the parents, we created some goals which included being able to drink from a cup that was a cup other than a baby bottle. We also looked at being able to improve our feeding, so tolerating new foods, specifically with this client working on tolerating different colors of food because we were very selective. We also worked a lot on sensory regulation, so being able to like calm our bodies in a sense, and we'll get more into that on another slide. We also looked at improving our attention span across various settings and also that lower body dressing that's required in order to then start toilet training.
And then for speech therapy, you might see some of these goals repeat a little bit that you saw in OT or in ABA, but we're again looking to improve that attention and engagement to communicate with others. Those are the building blocks. If we don't have the attention, it can only be 10 seconds. If it's only 2 seconds, 5 seconds, 10 seconds, and we build from there, that's completely fine. But if we don't have the attention, we're gonna have a hard time being able to understand what's happening in the world around us and be able to communicate. Speech goals also include wanting to increase his vocabulary of what everyday common objects are, understanding and following directions, whether it's at home or in the classroom setting or in the clinic, requesting and protesting his wants and needs appropriately. And this was a big thing. When Philip doesn't want to do something, he says no by screaming and throwing himself on the floor. I want him to just say no. Or just shaking his head, that's it, so that we can reduce that frustration that the parents are expressing in terms of every time he doesn't want to do something, he screams. We just want to turn that into a little, no, it's okay if he doesn't want to do it. And then eventually at the bottom, expanding that speech sound inventory. So we have a lot of goals that we're going to work on until we start improving the articulation or the sounds that he's going to be saying. And then let's talk a little bit about the collaboration that speech and ABA are doing, since we do have a lot of common things that we're working on when it comes to communication, and this will happen for OT as well. When Christine and I were chatting together, we really discussed having meaningful words to work on in between settings. So one of the challenges that Philip runs into is what a lot of our kids do, compartmentalization. So he may do it for her and her team, he doesn't do it for me. Or he sees the picture of the car, but it's only the one picture of the car or the shoes or the rice or whatever he's been working on. But if I show him a similar but different picture, it's hard for him. So we kind of chose words that we could both work on and then have the same pictures going back and forth from her work at the table to then when he comes to see me for speech, so we get that consistency. And that helps me work on speech sounds and whatever we need to work on. And then behavioral intervention for transitions to speech, we see him for 20 minutes for therapy, but because he was having difficulty separating from his technician and we were having some breakdowns there, I wasn't having much meaning in my therapy sessions because it was hard for him to transition. So I wanted to come to Christy and say, hey, could you help me out with this? And she was able to come up with a great intervention plan to help him transition. And I said, okay, tell me what you need. We can keep the door open. The tech can stay. We'll fade him out over time. And it's worked out beautifully because it's been able to help improve his ability to transition. Now he can sit and attend for his speech therapy session, and he's making so much more progress. So we're kind of killing two birds with one stone there. And then we talk consistently about modifying his pecs. Again, we use evidence-based practice, of course, what the research is supporting. So if you're familiar with that picture exchange communication system, there's a lot of research behind it, which is fantastic. But some of the aspects of it were not quite working for Philip, so we actually created something that was individualized for him, where he has just his foods on one page and he can point to what he wants instead of in a book. So we just modified it a little bit and talked about what was working across settings, and it's working really well for him.
So from a collaboration perspective between OT, speech, and ABA, we worked a lot on our sensory regulation as well as some oral sensitivities. So first with our sensory regulation, we worked a lot on some sensory diet activities. And if you're not familiar with a sensory diet, it really just looks at different types of activities that are individualized to each kid and what their sensory needs are. So for example, if you have a kid that's seeking out the running, jumping, climbing, crashing, we can pick specific activities such as swinging in a lateral motion for 10 minutes versus then maybe pulling a heavy cart, which can help give our bodies that input that they're seeking. So we can kind of tailor this to each kid and figure out what works for each kid, because what works for one kid does not always work for another, even if it's the same sensory issue. So we really look at this and create an individualized plan. So with this, we worked on, specifically with Philip, a weighted vest and using the swing. And what we really worked on collaboratively was also teaching the ABA techs, like what is working versus what isn't, so that way they can apply those same methods to hopefully get a better outcome. And then mostly with speech, we were having a hard time getting that attention to attend to the speech language session. So we would don a weighted vest, put it on him before he went into his session, and then I would attend his speech session with him to kind of see, is it working, is it not working, are we able to bring this into a different setting, and just kind of help out in speech as much as we can to get the same effect that he's getting in my sessions with OT. So we just want to make sure we can kind of bring that across the board. Same thing with the swing. For him, it really worked to do 10 lateral motions, 10 rotary motions, and 10 spinning motions. So something as simple as that might work for your child, and then just letting other people know, hey, this is really improving, and we're seeing a little bit of increased focus and attention to meet some of those goals after performing these activities can really help. We also had some sensory regulation issues with tactile sensitivity. So as she mentioned earlier, tolerating different clothing. So this kind of came down to desensitizing our system, being slowly, gradually getting used to wearing different types of textures or different clothing, specifically hats and gloves were kind of an issue at first. And then kind of building that tolerance, but also then training the ABA techs on doing the same thing, because while I have him maybe for 45 minutes, he's in ABA way longer than that, and they can carry those same methods over to really produce a nice outcome more than what I can just do in my limited time with him. And lastly, we had some oral sensitivities. So I originally, as I mentioned, had a goal to tolerate using a different cup other than what you would consider like a baby's bottle. And we were really struggling with this one, as well as gagging when it came to new foods and a lot of just sensitivities in that area. So I was treating it as a sensory perspective. However, our speech language therapist came along and actually saw that Philip had a lip and a tongue tie, something I'm not trained to know about. And so her collaboration of identifying this issue, which caused a lot of sensitivities in his mouth, then we were able to talk to our parents, and the parents then had a surgery done to eliminate that issue that we were having. And immediately after healing, we got rid of the cup, went right to a straw, and started introducing new foods to our diet. And there's still some other sensory issues along with it, but it was a dramatic change just from collaborating with speech and being able to figure out what was truly going on. So collaboration with OT, ABA, and home, so adding that home component in here. We worked a lot on potty training and that food selectivity. So potty training, me and Christy really worked a lot together on how can we make the bathroom a less scary place. And from an OT perspective, I was looking at, is it the cold or the bright lights? Is it the splashing of the toilet or the sound of the toilet flushing? What is it that truly is bothering us, or is it just the fact that it's not something we're used to and we just need to slowly accept that that's a new environment? We also then, from my perspective, looked at a lot of clothing skills. So in order to potty train, we have to be able to pull our pants up and down, or pull up and down, and skills along those lines. So we worked a lot on that. That way that precursor skill is already in place. That way when we move on, there's one less thing to worry about, because you think about going to the bathroom, it's something we do every day and we take kind of for granted. You think about the entire sequencing and processing that goes on there. You have to make sure you take your pants down, then you sit, then you have to make sure you use the bathroom, you wipe, you flush. There's a lot going on there, so whatever we can do to reduce how much there is that we need to do can make it a little less scary for when we get to that point. We also worked on our food selectivity. So this started with feeding therapy in the clinic, kind of just trial and error, figuring out what methods work for us, which don't. And when I got that down, we then pulled in the ABA techs to kind of show them how we're doing it. How are we accepting new foods? How are we tolerating this change in our diet? And then once again, it was something that I can only work on once a week, but they're able to work on every day. And then we're currently in the process of having that tech go into the home to help bring that skill into the home, because we're kind of compartmentalizing right now, and we eat with this person, we eat with that person, but we don't eat with mom and dad at home. So we're kind of working on that skill, collaborating together to better outcome in the home setting. And then lastly, we also, with our feeding selectivity, we worked on some parent observation and education, because that is a huge component. So having mom come in and watch, see what's going on, constantly in collaboration with mom and dad about what foods do we want to add now that we accomplished this food, which foods are we going to have that day to send with the tech to work on versus what foods are we going to work on with me, and just whole component collaborating together in that aspect.
So I'll talk a little bit about my collaboration with Philip's school. Unfortunately, COVID restrictions have not allowed me to get into the classroom to actually see him there. But I have a decent rapport with his teacher. I actually had seen that teacher in some virtual school with another client. So we had a good relationship, and our most recent communication gave me the dreaded news that although he had been acquiring a lot of new words in ABA and in speech, they weren't happening at school. And as we said, you know, he's not meant to be in therapy forever, but that school system's going to be with him for the next 18 years. So it's important that he does those things there. So instead of my focus being, let's get him a bunch of new words, we've kind of halted and said, we're not moving on until, you know, he's got 10 different examples of this word, and he'll do it here and there with this tech and that tech and the owner and whoever comes by, to hopefully see better generalization of that into his classroom. In addition to those transitions between people, which I'll talk about in a minute, she brought up something that I didn't even know was an issue, and that was that transitioning between activities themselves really ended up being like physically prompted, because he wasn't attending to the instruction and wouldn't really move on his own, not behaviorally per se, but he just didn't know where to go. So I made a goal. You know, our clinic is large enough to where I could make these transition goals, and I made a little visual, and he's doing well, and I've been able to kind of give that to school and kind of help them see that, you know, with some visual support and gestures, that he was able to complete those tasks. And then, like we mentioned with the preferred people leaving, initially the teacher gave me some really like sweet language and verbiage that they were using with him, that when it was really challenging right in the beginning, you know, we were using that all the time, so that he was hearing the same words, that I'm going to be right back, it's going to be okay, you're okay, you know. And we would say the same thing, so that it was almost a cue that, okay, they are leaving and it is going to be okay. And like Susan mentioned, thankfully, with using some of what they've done in our strategies, this problem is so much better now. And I think that kind of wraps up, that wraps up our, you know, one case study. We had many others, but we felt like Philip had a lot. He had a lot of overlap between all of us and school and mom and home. So we wanted to kind of give you specific examples, but now we'll shift gears, and Ashlyn will kind of talk about how you can select really good providers to have on your team.
All right, thanks, Christy. So now that we've identified with you guys what each service does, how they can collaborate together, why that collaboration is so important in the setting, we're now going to get into kind of the nuts and bolts of like how to assemble your team. What are some things we can think of when we're selecting a new provider or a new clinic? So unfortunately, we got to first off share the bad news with you. There's no formula you can apply to just find the right therapist. And this is really challenging. However, we did give you guys a handout, which we're going to cover next, that kind of gives you some tips and tricks on things you can look at, things to ask, things to think about when you're on a tour or meeting a new person that you want to consider to find the right fit for your child's team.
So yeah, we'll kind of go over some of the questions that you're going to see. But first, there's some things that you can keep in mind that might not be, you know, in a pretty question format. And I think that first and foremost, personality is so important. You have to be able to get along with the person that is going to be overseeing your child. You have to feel comfortable with sharing sensitive information, you know, with them about things that might be going on at home that may be affecting the child. And it should be someone that you're really comfortable talking with. Of course, location and hours are going to be really important for you to look into before even getting out for a tour. If it's too far away, cross that one off your list and kind of look at what's next. Or if you really need evening hours and they don't provide that, cross that one off your list, go to the next. And then when you do get out there and you get on your tours, take a look at the clinic atmosphere as you're walking through. You should be able to kind of notice kids working and people working with the children, and do they seem happy? Can you picture your child in that setting? Is it clean? And ultimately, are you getting those like warm and fuzzies that, yeah, like this is where I want my child to come? And then more specific general questions for any provider are listed. you want to think through, do I want to be center-based, or do I want people to come into my home? Observation is important. I think as parents, we all want to have the green light that if we want to come see what's going on, that's okay. Parent training, what does that look like? How often is that going to happen? Again, any provider, asking how might you handle this challenging behavior? And if you have behaviors in mind, get specific. Maybe Johnny kicks. Johnny kicks me all the time when he doesn't want to do something. How might you handle that in your session? And the way they respond should give you some insight as to what their training is like. Will you work with my school? And then we also put the cancellation policy on there because something you might not think about, but some clinics, if your therapist is sick, your child's session might be canceled for that day. But others might have, backup people that you're familiar with, and maybe person A is sick, but you've got B and C as backup. So that might be something you want to look into and check in about. With ABA, there's kind of two main players on that team, and that's going to be your BCBA and your behavior tech. The BCBA, kind of checking in, there's a lot of new BCBAs out there, which is great. There's a big need, but kind of asking, how long have you been in the field? How long have you worked with children with autism? How many kiddos are on your caseload? That can be telling. That can range a lot, from like 4 kids to 25. And so, of course, the smaller numbers, you know that your child's going to get more individualized attention, and those really big caseloads just make it literally physically difficult to see your child as much as you might want them to see your child, or you for that matter. And then you might be able to get into a bit more detail with your BCBA about challenging behavior, and you can ask them, do you have special training in managing those behaviors and kind of working with that. For the behavior tech, we'll acknowledge a lot of behavior techs are young, and they're trying to figure out what they want to do with their lives, and they know they love kids, and so they kind of land at an ABA clinic, which is many times wonderful, but just kind of digging into how do you select a behavior technician? What qualities do you look for here? How long is their training? Does it continue after they're initially trained? A big one is, how often will the technician switch? I hear from most parents, I don't want to see a new face every day. I want to know that Susie is going to be there waiting at the door for my kiddo, and I know he'll be successful with that. So kind of asking right off the bat, what can I expect there? Asking about turnover rate. Unfortunately, with the young children population that tend to be behavior techs, they're anywhere from 20 to 25. They do get jobs and they do move on. So just kind of asking that clinic's history with turnover and what that looks like for them. How often is supervision provided to them is a big one. And then another big thing is, what if I just don't think they're a good fit for my kid? What if I'm getting weird vibes and my child isn't happy to see them? How are you going to handle that if I bring that up to you? And kind of hear your clinic out and see what their policies are on that.
All right, so things to consider when looking for a speech therapist. I mentioned earlier in the presentation that speech pathologists cover quite a gamut, so we are not as specialized as ABA in working just with folks with autism. So when you're looking at an SLP, you want to ask them, what is their philosophy with working with children and with a variety of abilities and medical diagnoses? Again, because they do cover a large area. You may want to ask, what types of assessment tools do they use in diagnosing those speech challenges? Are they just using those textbook type assessments, or are they doing more dynamic assessment, right, where they're observing in the home, collaborating with the team, and looking outside of where you can just check the boxes to really get a big picture of what's going on? You want to ask what happens in a typical speech therapy session. What are some treatment approaches? What do you do when, so-and-so doesn't want to do this task that you've, created? Or do you do all your work at the table, or are you out with your running shoes on that swing, or, having more movement in your session? So what do those sessions look like, and what are some different approaches that they try for different treatments? You want to look at how does the SLP involve the family in making those treatment decisions? Again, what might be important that the speech therapist might be thinking initially based on their breakdown of their sounds or the words trouble. They may come up with a list of words they want to work on, but does that match what you guys as the parents want? And make sure that you're involved in that process. How do they collaborate with other professionals? Again, we don't work in a silo. We want to work out with a team, so that's important as well. And you want to ask, does the SLP have any specific skills or training in any specialty areas within pediatrics, which would include child apraxia of speech, swallowing challenges, or AAC, augmentative or alternative communication? If they don't have necessarily years of experience with apraxia, or they don't have years of experience with swallowing or AAC, do they work in a clinic that provides support? And what does the training look like for professionals, right? We're all required to get ongoing CEUs. So from personal experience, I've worked with autism to Alzheimer's disease. So, I've had to retrain and things like that. So you just want to look for that to make sure that they're keeping up on those latest methods.
So when it comes to choosing an occupational therapist, first we're going to think about some questions for your child's actual OT. So first off, once again, kind of like Susan said, do we have specific training in assessing and treating kids with autism? How long has your experience been in this area? Very similar, we work in all variety of fields, just like speech from the NICU all the way into hospice. So we kind of want to gauge that interest, see how long that's kind of been their thing. Is there any special trainings or things that have really brought them to the field to have that experience among kids with autism? We also want to consider your child's OT provider. So kind of different from speech, in a lot of settings, you might have an occupational therapy assistant who is providing the treatments for your child. So if that's okay, even if that's the case, you may just want to ask, is it you that's going to be treating my child? Because the OT is going to be the one doing your child's evaluation. You might just want to ask, is it going to be you or is it going to be someone else? Can I meet them? What are they like? And then you also probably want to ask, what is that assistant's supervision like? So some clinics, it might be more remote, a phone call here and there, just kind of reading over, co-signing notes. And in other settings, it's going to be a lot more direct supervision. So the OT's in those sessions, overseeing each kiddo and really engaged in each case with their assistant. We also want to consider some questions about our occupational therapy treatment. So what does a typical session look like? What assessments is it that you're using? What different areas do you look at? So we want to make sure, kind of like how we mentioned, the school might look a little bit more at those like fine motor skills, the writing and scissors. We might want to make sure that OT in the session does have some training in sensory mechanisms, or will address my child's difficulty getting in and out of a car, or those gross motor and balance abilities, and making sure that whole picture is being addressed. We also might want to ask, do you have a sensory-rich environment for treatments? What kind of equipment do you have? This is the equipment my child likes to use at home. Do you have similar things here? And then last but not least, do you provide intensive treatment? So research has really shown that providing treatment more than once a week is really going to be the best option when it comes to getting those good outcomes and meeting those goals. So just asking them, like, how often is my kid going to be seen? Like, on average, what is your average kid here? Is it 3 times a week for 45? Is it every day for 30? Kind of gauge what that clinic does and what they think would be the best fit for your child.
So, with all of that being said, ultimately, you have to trust your gut as your child's caregiver and parent. You're their best advocate. And I think there's a lot to be said about your own intuition and what you think is going to be a good fit for your kiddo. So listen to that. In addition, main things are that you have people that are listening to you and they're validating you. You can trust that if they say they're going to do something, they do it. If they're reaching out to your teacher or they're putting in a program, you know that it's happening. Huge thing here would be communicating regularly and openly with you. Our kiddos are going to have amazing days, and then they're going to have some tough days. And especially if your child can't explain what happened, you really need to trust that whoever saw your child will be open and honest, even if it's, an uncomfortable conversation. lastly, they should really make you feel like you're the team captain, like we said at the start of this. You know your child best, and what you say has more value than what any of us could say about your child. And after all, no one will advocate for your child like you will. Even, sometimes it seems like the experts might have all the answers or know everything, but we love this quote. I think it sums it up perfectly, that you will always know more about your child than the experts, and sometimes what you know may confound or confuse them, but that does not make you wrong. And we hope you can remember that and take that sentiment with you, along with all the other information we shared, to get out there and kind of fight for what collaboration might look like for you and your family. And then on our last slide, there's just a couple resources for you. The Autism Alliance has an amazing service directory where you just punch in your zip code and you can see all the services in your area. There's some information about IEPs and 504 plans. I know personally those can be really confusing, so a little extra info for you is at that link. And then if you think of a question down the road that you wish you would have asked and you forgot, we put up our email address there for you, and you can reach out anytime.